Yeah, hello to everyone. Thanks for having me. Thanks to the Magnus Group for organizing this quite unique conference, I guess. And to let me talk about the minimally invasive foot and ankle surgery, and especially to the Talo Navicular arthrodesis. The kind-looking lady on the left is the head of office who intentionally wanted to attend the conference, but unfortunately wasn't able to. So that's why I'm here for you today. I have no financial or personal conflict of interest related to this presentation. So first of all, I want to give you a little overview about where I'm from. As mentioned, I'm from Germany. I work in the University Hospital of Halle, which is located in the eastern part of Germany and in the southern part of our federal state, Saxony-Anhalt. And I think even though we saw a city from Nepal, also Halle is quite a unique city, I think. And in the background, you see our relatively new university hospital where I work until today. So let's talk about minimally invasive TN arthrodesis. I'm going to talk about the indications and contraindications, advantages and disadvantages compared to the open technique. Then I give you a point-to-point presentation on the surgical technique. And afterwards, I'm going to present our radiographic and clinical outcomes. I talk about the study limitations and I give a little outlook. So to keep it short, some background information. The TN joint, as you may already know, is essential for hindfoot biomechanics, especially the in and eversion. In combination with the calcaneocubic joint, it forms the Chopin joint. And of course, it plays a major role in stabilizing the medial longitudinal arch. And so it's central to both the development and treatment of pes planovalgus deformities. Degenerative changes, for example, arthritis or osteonecrosis, often result in significant functional impairment and pain. And yeah, these are the typical patients that we see at our university hospital. They have degenerative changes in the TN joint and complain about pain and functional limitation. So thus, the TN arthrodesis is a well-established procedure to restore alignment, improve function, and reduce pain of the patients. And the traditional open techniques, and it is something that you have to worry about, require tissue dissection with associated perioperative risk. So this is a classical open approach to the TN joint where you, as I already mentioned, dissect the soft tissues and then restore the alignment with plates or staples or screws. And the MIS TN arthrodesis aims to reduce the surgical trauma while maintain a solid osseous fusion. So this is one sentence that we then talked about in our publication. Despite increasing interest in MIS techniques, the current body of literature remains surprisingly sparse and inconsistent. And this is especially when talking about MIS foot and ankle surgery and not other fields of orthopedic surgery. So what about the indications and contraindications to do the TN arthrodesis minimally invasive? We have primary and secondary TN joint arthritis, osteonecrosis of the os naviculare, rigid pes planovalgus or carbovarus deformities, failure of conservative management, and medial column instability and flat foot reconstruction. Talking about contraindications, we have acute local infection at the surgical site. This is, of course, not special for the TN arthrodesis, but for other procedures as well. Severe systemic comorbidities, for example, high anesthetic risk, advanced peripheral arterial disease, uncontrolled diabetes, severe osteoporosis. These are relative contraindications. And we do perform the MIS TN arthrodesis in these patients as well. So to present the clinical case, we have a 60-year-old male patient with classical symptoms, chronic hindfoot pain. Walking distance is limited to around 100 meters, and the patient had pressure tenderness at the sinus tarsi. At our clinical findings, we found a pronounced flexible flat foot deformity with restriction of the ankle joint, and the patient had no neurological or vascular deficits. So when we had this patient in our ambulance, of course, we performed some X-ray of the joint, and then we saw a stage 3 pes planovalgus and activated TN and subtalar arthritis. So our plan was then, of course, these patients, if they are not complaining about chronic hindfoot pain, you actively would treat them conservatively. But if this fails, then you plan to do surgery. And in this case, we planned this screw arthrodesis of the subtalar and the TN joint. So when talking about TN arthrodesis, and planning to do a mis-TN arthrodesis, you have to know about the advantages and disadvantages compared to the open technique. So the Talo Navicular arthrodesis in general aims to reduce pain, correct deformity, and restore the functional biomechanics of the medial column by achieving solid osseous fusion of the TN joint. And this is what you have to keep in mind, whether you do perform an open or a mis approach. This is the one thing that you have to know about. So what are the advantages of the MIS technique? Of course, we have a reduced soft tissue trauma. We have potential lower risk of wound healing complications, also potential lower postoperative pain and use of analgesics, potentially shorter operative time, faster functional recovery and early mobilization, and a reduced overall mobility, especially in high-risk patients. For example, these ones who are smokers or have diabetic disease. What are the potential limitations of the mis-TN arthrodesis? You have no direct joint visualization compared to the open technique. It is technically more demanding. It requires specialized instruments, for example, a special bore system. You have greater reliance on intraoperatively or intraoperative fluoroscopy, and this is this leads to increased radiation exposure. And you have a steep learning curve, so maybe the technique is not ideal for all surgeons or surgical centers. So now let's get into the surgical technique. Before you operate patients, I hope you do a clinical evaluation. You have to look at the hindfoot alignment, the range of motion, like we did in the clinical case, palpation and neurovascular check. And after that, you do your imaging. In our university hospital, we normally just do weight-bearing X-rays in our AP or DP projection. And if you need to know more about soft tissue assessment, you do the MRI, or if you do want to know about the bone destruction or correction planning, you have to do your CT imaging as well. So, and after that, and after you planned the surgery, first thing you need to do is to position your patient. You have to do, or not you have to do, the anesthesiologist has to do a general, regional, or spinal anesthesia, optional placement of a nerve catheter for perioperative analgesia, and then you position your patient in a supine positioning with wedge support under the ipsilateral pelvis to control the internal leg rotation. You do your sterile draping, optional pneumatic tourniquet, and your single-shot antibiotic prophylaxis. So the second step is to select the portals. You identify and mark your anatomical landmarks for planned portal sites. Usually we do 2 portals. One is located at the medial and one at the dorsolateral aspect of the foot. The medial portal, you have to keep in mind that you have to place a dorsal to the insertion of the tibialis posterior tendon. After that, you do your skin incision and joint access. you have to position your X-ray, because you need to guide the borer afterwards, or after you did a skin incision, and this is what you do with the X-ray. Radiographic marking of the portal locations as marked anatomically before, and then you do your skin incision and carefully soft tissue handling to avoid injury of neurovascular structures. After that, you insert your straight bore, and then well, you insert it percutaneously via the medial and also lateral portals, and therefore you have to keep in mind to align the bore trajectory with the joint plane. And then you can check under the X-ray the positioning of your borer. You have to position it intra-articular and monitor it continuously via X-ray. Then you need to you repeat your radiographic checks to confirm the correct depth and direction of your preparation, and the progressive blurring of the joint contours under the X-ray are used as an indicator of adequate cartilage removal. After you did that, you put out your borer, and then you temporarily reposition your joint in the intended corrected alignment. You temporarily fixate it with K-wires, and then you check again with X-ray if the alignment is correct. And if so, then you drill or you over drill the K-wires and compress the TN joint with 2 cannulated compression screws, usually 6 to 6.5 millimeters. And the screws are inserted alternatively from the medial and also lateral portal to ensure even compression across the fusion site. Yeah, and then of course you do final X-rays to check if everything went right, and if so, then you have to do your wound closure, layer closure of the xenostasi approach, like we did in this case, the closure of percutaneous incisions as needed, and of course application of steroid dressings. And after you did your operation, you also have to keep in mind the postoperative care. So we in our hospital center, we ensure the patients to elevate the leg and do cryotherapy to reduce swelling. The patients, of course, have analgesia regime to the WHO pain letter, considering the pre-existing medication, thromboprophylaxis until full weight bearing is achieved, and early initiation of manual lymphatic drainage. And after they leave our hospital, we put on for 6-week postoperatively a below knee walker, boot with forearm crutches, and say to the patients that they have to touch down weight bearing. Suture removal is usually at 14 days post-op, unless resorbable material was used. Radiographic follow-up at 6 weeks to access the osseous consolidation of the TN joint. And then when we done this, then we gradually increase the weight bearing in an orthopedic boot from 6 weeks, and full weight bearing is normally allowed in a stable shoe with rigid sole from week 7 onward. Okay, what are the outcomes in our population? We treated a total number of 29 patients on our MIS technique. We had 12 cases where we did an isolated TN arthrodesis. In 9 patients, we additionally did a calcaneal osteotomy, and in 8 subtalar arthrodesis, like in the clinical case I showed you before. The indications, as I mentioned, were isolated TN arthrodesis and TN pathology in pes planovalgus or pes cavovarus deformities when treating the TN joint. The demographics, our patients were 55 years old, and we retrospectively did or showed the surgery period in the past 3 years. And the mean follow-up of these patients were 131 days. So what are the radiographic outcomes? The radiographic alignment assessed using weight-bearing dorsoplantar and lateral tarsometatarsal angles, and we compared them pre to post-operatively. And what we saw in both angles, so the dorsoplantar and lateral TM angle narrowed to had a near neutral alignment and a marked reduction in variance, even though we nearly missed statistical significance. So we concluded both radiographic planes demonstrate a consistent postoperative correction with a strong tendency toward normalization, reflecting an effective realignment achieved through the MIS approach or arthrodesis, despite the absence of direct joint visualization. So what about the clinical outcomes? Therefore, we looked at the AOFA scores pre and post-operatively. We had a mean pre-operative AOFA score of 54 points, post-operative 90 points, and so we had a mean improvement of 36 points, which was statistically significant. We then did a subgroup analysis to show if patients benefits from this surgery procedure, if they have a low baseline or a high baseline score, depending on the AOFA score. And we divided our patients into two groups. Group one was with the low AOFA baseline score, and group two was the group with the high baseline score. And we saw in group one with a lower baseline function, greater relative functional gain with good post-operative results despite low starting point, and at our high baseline subgroup, smaller relative gain, but excellent absolute outcomes as well. So it doesn't depend if your patient pre-operatively has a good or bad AOFA score, they both benefit from the surgical procedure. What about complications? We had 0 wound infections, neurovascular injuries, or implant-related complications in our cohort, except for one prolonged wound healing on the calcaneal side of one patient. The radiological follow-up showed in all cases complete osseous consolidation of the TN joint, and no revision surgery in the MIS group during the follow-up was needed. So what are the study limitations? Of course, it's a retrospective study design with a limited sample size because we only had 29 patients in our group. We have a relatively short follow-up period with 131 days. And of course, we had no control group within the same institutional setting. Functional outcomes were also not compared to open approach or arthrodesis in an RCT design. What is the outlook? Of course, we need prospective studies, controlled randomized trials to validate our findings in the MIS retrospectively group. We need to define long-term outcomes and data required fusion rates. We need a broader implementation or evaluation of the MIS technique in multi-center settings and across different surgeon experience levels. We have to standardize the MIS instrumentation and approach, and maybe there's also a possible way to integrate or navigate our screw insertions by robotic assistance. And last but not least, the patient selection. We have to identify subgroups that are most likely to benefit from our MIS approach, and we have to develop risk stratification tools to find which patients really profit from our MIS approach. So to conclude, the MIS TM arthrodesis has proven to be a safe and effective technique that offers reliable correction and low morbidity, even in complex deformities. With further validation, it may well become the standard approach for selected patients in the evolving field of reconstructive foot surgery. Thank you very much.